Well, again, good afternoon. Welcome. Thank you for joining us for today's webinar, The Role of Federal Agencies in Supporting Women with Autoimmune Diseases and Conditions. I'm Katie Schubert. I'm President and CEO of the Society for Women's Health Research. And SWHR was founded in 1990, and we are dedicated to promoting research on biological sex differences in disease and improving women's health through science, policy, and education. And we're convening today's event as part of a four-part webinar series to bring attention to the impact of autoimmune diseases and conditions on women. Our previous webinars were focused on the burden of autoimmune diseases on women and coverage and access issues affecting women with autoimmune diseases and conditions. And the recordings of those events can be found on our website, swhr.org. Before we move into today's program, I want to review just a few details and housekeeping notes. First, SWHR would like to thank our sponsor, Horizon Therapeutics. Without your support, we would not be able to have these webinars. So we appreciate that as always. And then also just a few true housekeeping items here. Note that we are recording this event. We will be posting it online. We will send out the recording and any resources that are mentioned in the follow-up email to registrants. To ask a question during the event, please use the Zoom Q&A function. You could also use the chat function. Both of those are at the bottom of your screen, and we will ask questions at the end of the event following all panelist presentations. And if you need technical assistance, please write in the chat function, but note that we do have limited technical assistance available while the webinar is running. And you can see the note here, there's a live transcription feature available on our webinar, and you can access that feature by clicking on CC Live Transcript at the bottom of your screen. If you do not see it, which sometimes happens, you may need to resize your window to have it be a little bit wider. So with that, I would like to introduce SWHR's Chief Advocacy Officer, Lindsay Horan, who is moderating today's event.
Thank you so much, Katie. And today we welcome four incredible panelists who will discuss how federal agencies, through their respective mission, programs, and initiatives, support women with autoimmune diseases and conditions and work to improve their health outcomes. Dr. Nicole Bashi is the Director of Regulatory Affairs at the National MS Society, where she works to build relationships with federal agencies to achieve a world free of MS. Dr. Robert Colbert is Clinical Director, Senior Investigator, and Head of Clinical Research at the National Institute of Arthritis and Musculoskeletal and Skin Diseases, or NIAMS. He is a board-certified pediatric rheumatologist and completed his postdoctoral research in molecular immunology, and he has served as professor of pediatrics and chief of the Division of Rheumatology at the University of Cincinnati and Cincinnati Children's Hospital Medical Center before joining NIAMS in 2008 as the chief of the Pediatric Translational Research Branch. Dr. Marie Mancini is the program director of the Systemic Autoimmune Diseases Biology Programs in the NIAMS Division of Extramural Research. Prior to joining NIAMS in 2007, she was a research scientist at a biotech company where she focused on preclinical studies in the areas of autoimmunity and inflammation. Ms. Taryn Williams is the Assistant Secretary of Labor for Disability Employment Policy. In this position, she advises the Secretary of Labor on how the department's policies and programs impact the employment of people with disabilities and leads the Office of Disability Employment Policy, which works with employers and all levels of government to promote evidence-based policy that improves employment opportunities and outcomes for people with disabilities. Her background includes a long history with the Office of Disability Employment Policy and positions at American Progress and the U.S. Senate Committee on Health, Education, Labor, and Pensions. We're so looking forward to having you all here for today's discussion. So without further ado, I will turn it over to Dr. Colbert, who will walk us through the NIAMS Intramural Research Program. Dr. Colbert, over to you.
Thank you, Lindsay. Let me start sharing my slides. And just have to get it on presentation mode. Great. Does that look okay?
It looks great. Thank you.
Super. Well, thanks very much for the invitation. I'm really delighted to talk about the work of really a number of people in the intramural research program in NIAMS. My colleague, Dr. Mancini, will talk a little bit more, well, quite a bit more about overall efforts in NIAMS. The intramural research program is about 10 or 11% of the overall NIAMS budget. And we're located, of course, on the NIH campus in Bethesda, Maryland. So in terms of the diseases that we study in the intramural program, a number of them are autoimmune diseases that are much more common in women than in men. So I will spend a little bit of time telling you some things that we're doing in systemic lupus erythematosus, which, as you can see, is very much predominantly a female disease. Systemic sclerosis and scleroderma, also much more common in females. We have some genetic research going on in that area, which I won't go over today. We also have a couple of different groups studying inflammatory myositis. One of them is focused on adults with this disease, and another is focused on children. And again, I won't be focusing on inflammatory myositis in this talk. We have a couple of groups also studying juvenile idiopathic arthritis. And some forms of JIA in children are more common in girls than in boys, in particular oligo and polyarticular JIA, whereas systemic onset juvenile arthritis is about 50-50 male and female, and spondyloarthritis is more common in men than in women, and also more common in boys than in girls. We have some collaborative work going on in primary Sjogren's syndrome, another female predominant disease. And those collaborations are on a trial of a drug called tofacitinib, and that's actually run out of the NIDCR, Dental and Craniofacial Research Institute, but it's a collaboration. So I thought I would highlight a few studies that have come out in the past 3 years or so from our NIAMS lupus clinical trials unit, and a couple of studies that are ongoing in that area. And then I'll tell you about a couple of upcoming trials as well. Since I'm going to spend a minute on the exercise training work, pioglitazone, tofacitinib, and sex differences, I'll just jump to an ongoing project, which I won't talk more about, but we have investigators very interested in understanding genetic predisposition to lupus in a multi-ethnic cohort, and also in children. There is a stronger genetic component to very early onset lupus, and we have investigators trying to better understand what predisposes people to developing lupus. So this study, which was published in 2022, is actually quite interesting. It looked at exercise training in women with lupus, and it was a collaboration between investigators in NIAMS and in the NIH Clinical Center Department of Rehab Medicine. There were 16 women, excuse me, with lupus who were studied. They had fatigue was a significant component of their disease manifestations, and they underwent a vigorous 12-week exercise program with various measurements of whether they improved or not, including measures of anaerobic threshold, a walk test, and fatigue scores. Investigators also looked at part of the immunology of lupus, an interferon score. What was quite interesting is that this exercise program improved cardiorespiratory function, reduced fatigue, improved mitochondrial function, and surprisingly, 9 of the 15 patients had reduced interferon scores. An interferon score is a measure of some of the inflammation that's going on in the peripheral blood. This study was, highlighted in our intramural program in the IM intramural blog, and I just wanted to give a shout out to Dr. Chin from Rehab Medicine and Dr. Hasni from NIAMS, who were the senior and first authors on this paper. A second study represents some of the work that Dr. Mariana Kaplan, internationally known investigator in NIAMS, her work in lupus. She's particularly interested in vascular and metabolic dysfunction in this disease. And this was a trial of a drug called pioglitazone, or PGZ. And the reason they tried this drug is to see if it might have any effect on cardiovascular disease risk. So premature cardiovascular disease is very common in lupus, and of course is associated with increased morbidity and earlier mortality. They studied 80 subjects, predominantly women with lupus, who were treated in a double-blind crossover design, and the results were actually quite impressive. They showed that this medication improved vascular stiffness and other cardiometabolic parameters, suggesting that a non-immunosuppressive therapy could decrease some of the important cardiovascular risk parameters in lupus patients. Another study that was recently completed and published in 2021 was a study of a JAK inhibitor called tofacitinib. This was an early phase study, again, looking at outcomes related to cardiovascular disease. 30 subjects were randomized 2-to-1 to receive tofacitinib versus placebo, with the primary outcome being safety and tolerability. And again, evidence for improved cardiometabolic parameters, improved immunologic parameters, and it reduced a population of low-density granulocytes and neutrophil extracellular traps, which are highly associated with the pathogenesis of this disease. So very promising results in a small study that will be followed up in other studies. This is a study published in 2020 asking the question about why diseases like lupus may be more common in women than in men. And they were studying neutrophils, which are important blood cells that are involved in, they're very involved in lupus, but also involved in fighting infection. The mechanisms responsible for differences in how women and men respond to infection, but also why women develop autoimmunity remain unclear. And so in lupus, they asked whether there were differences in neutrophils. And in fact, they found that healthy young adult females have more activated, mature neutrophils with an enhanced type 1 interferon pathway, and enhanced pro-inflammatory responses, as well as distinct bioenergetics. These differences are likely related to differences in sex hormones, and the group is now studying in a more in-depth way what this means and how these differences arise. And of course, this has potential therapeutic implications. So I'll finish up by just telling you that there are 2 trials that are about ready to start. One is studying a drug called anifrolumab, which blocks some of these interferons that I talked about. It blocks them by blocking the receptor that they work through. And this is a phase 2 double-blind placebo-controlled trial planned for 30 subjects, again, randomized 2-to-1. And they'll look at safety and tolerability with additional measurements of vascular function and immunologic parameters. This drug has recently been approved for lupus, But in terms of whether it improves vascular function, is a very important question. They will also be looking at whether a combined JAK inhibitor and SYK inhibitor called gusacitinib is safe to use in lupus, and whether there's any preliminary evidence for efficacy. And this is a phase 1 trial that's planned, again, with a 30-subject 2-to-1 randomization profile, where they'll look again at safety and tolerability, disease activity, pharmacokinetics, whether corticosteroids can be spared, and also cardiometabolic and immunologic parameters. So to summarize, we really have a lot of work going on in female predominant autoimmune diseases. I think the lupus program really leads the way in some of these efforts, and we hope that these will, in the long run, translate into better treatments and a better understanding of the disease and why it's so common in women. So that concludes my comments. I really thank the Society for Women's Health Research for all that you're doing to support these areas of research. Thank you.
Thank you for your kind words, Dr. Colbert, and thank you for the presentation. It's great to hear some of what NIAMS is focusing on in this space, so really appreciate your comments. Again, if you have questions for Dr. Colbert, please include them in the Q&A function or in the chat. I know we already got a few, but we will ask questions at the end of the event. So next, we'll turn it over to Dr. Marie Mancini, who will share a little bit about some of the extramural work NIH is focused on related to autoimmune diseases and conditions. So over to you.
Thank you, Lindsay, and thank you for the invite to speak here today. So next slide, please. I will give a short overview of the NIH, the complex institutes that they are, and an overview on the NIAMS in particular. And then I'm going to spend some time talking about some trans NIH collaborations and initiatives. And then with time, I hope to tell you a little bit about some exciting NIAM-supported advances. Next slide, please. So the NIH is actually made up of 27 institutes and centers, each with a specific research agenda, often focusing on particular diseases or body systems. And not all of the institutes or centers, which I'm going to use the acronym IC, institutes or centers, are directly supply extramural funding. NIH is the largest funder of biomedical research in the world. And as Dr. Colbert alluded to, approximately 81% of NIH's budget goes to the extramural world, as opposed to the research that occurs at NIH itself. And if you look at the budgets and the sizes, you will see that the NIAMS is actually a very small piece of the NIH. I think it's about 3 to 4% of the budget. And also want to point out that many of these ICs have overlapping research priorities. So the NIAMS is not the only institute focused on autoimmunity. Of course, the NIAID, with its focus on immunology, covers a lot of autoimmunity. And I can name most of the other institutes and centers that also have areas of focus on autoimmunity. Next slide, please. So the NIAMS, its mission is to perform research into the causes, treatments, and prevention of arthritis, and I will say arthritis and other rheumatic diseases, and musculoskeletal and skin diseases. It also is responsible for the training of both basic and clinical scientists to carry out this mission, and also dissemination on research progress. So again, just to look at the spending, about 84% of NIAMS budget is attributed to extramural research, with about 11% to intramural research. And then there's this 5%, which we call research management support, which is paying for our salaries and travel to meetings and some stuff like that. Next slide, please. So I'm not going to read all the diseases on this slide, but there are many autoimmune diseases that are of relevance to the mission of the NIAMS. And as Dr. Colbert discussed, SLE is one that's particularly female predominant, as is Sjogren's syndrome. Rheumatoid arthritis has about a 3-to-1 prevalence for women versus men. And I also included that NIAM supports autoinflammatory syndromes as well, such as, actually, Dr. Cooper did mention systemic JIA, and there's some other monogenic, probably pretty rare syndromes. I think there's a lot of discussion or debate of whether autoinflammatory syndromes are considered autoimmune, but we can at least say that they involve the immune system and they're inflammatory, and there's probably a spectrum of which disease could be classified as autoimmune versus autoinflammatory or somewhere in between. Next slide, please. So now I'm going to talk about some of the trans NIH initiatives and collaborations. The NIAMS leads a lupus federal working group to facilitate collaboration among the NIH institutes and organizations with an interest in lupus. So the HHS was charged, I don't know how many years ago, a while ago, with creating this working group, and the NIH designated the NIAMS as the lead. And actually, I with our institute director, Dr. Lindsay Criswell, are the co-leads of the Lupus Federal Working Group. We meet about once or twice a year. Next slide, please. A big program that you may have heard about is the AMP, Accelerating Medicines Partnership in Rheumatoid Arthritis and Systemic Lupus Erythematosus, also called AMP-RASLE. This AMP program has produced a rich data set for the research community. It was launched in 2014 to transform the way that we identify new targets for drug development. And this RASLE program was one of the original AMP programs. This program has the support of NIAMS, NIAID, and several industry and nonprofit partners. And this slide was some of the goals of the program. And the AMP-RASLE data are currently available to the public through these data management centers or repositories called dbGaP and also IMPORT, IMMPORT. Next slide, please. Building on the success of AMP-RASLE, NIAMS and several other NIH ICs and external partners launched AMP-AIM, AIM standing for Immune-Mediated Diseases. So this project expands beyond RA and lupus to psoriatic disease, psoriasis and psoriatic arthritis, and also Sjogren's syndrome. Next slide, please. And finally, finally with regard to AMP, another new collaboration under AMP is called the Team Science Leadership Scholar Program. This is being pursued in collaboration with the Office of Research on Women's Health and also with additional support from the Office of Data Science Strategy. This initiative aligns NIAM's goal of supporting team science in collaboration with the ORWH vision of preparing leaders in women's health research. And this program will support and train research scholars by helping them acquire and hone team science leadership and mentoring skills through an immersive cross-sectional and collaborative experience. And this program leverages the AMP-AIM infrastructure. Next slide, please. Another program that NIAMS is involved with is the NCI's Cancer Moonshot program. So just a little background. As you may know, immune checkpoint inhibitors are a new type of immunotherapy, fairly new, that work by releasing the natural brakes of the immune system. And they have revolutionized the treatment of advanced cancers in both children and adults. But since they are designed to enhance this anti-tumor immune response, they've also been shown to have some toxicities, such as eliciting what they call immune-related adverse events, or IRAE, which resemble autoimmune diseases and conditions. So there's been quite a fertile area of collaboration with NCI, with other NIH institutes, including NIAMS, to explore these IRAEs. For instance, the little picture on the right there, these immune-related adverse events are actually affecting all parts of the body, and what's circled in red and blue are the ones that are related to skin and rheumatic diseases, which is of interest to NIAMS. But as you can see, that is of interest to many other groups. And another, also the technologies that have been developed to treat cancer, such as immunotherapy technologies that are antigen specific, such as CAR-T, chimeric antigen receptor T cells, are now being brought over into the different fields. There's some pilot studies looking at specialized CAR T cells to treat lupus. So this is really exciting times. This one is near and dear to me because in my early career, I actually worked in the tumor immunology group at NIH. And I think the idea of the yin and yang of cancer and the immune system, there's a lot to be explored there. So we're grateful to have collaboration and be able to leverage some of NCI's funding. Next slide, please. Another trans NIH project is called Include, which is focused on Down syndrome to help focus on health and quality of life needs for individuals with Down syndrome. This was launched in 2018. And NIAMS, actually, I wasn't aware of this before I got into this, is that people with Down syndrome have a unique clinical profile, including higher rates of autoimmune disorders. And Down syndrome is an extra chromosome 21, and it's been shown that interferon alpha receptors are actually located on this chromosome, which might be one area of exploration for the increased autoimmunity in people with Down syndrome. So when NIAS was able to support a slot for pediatric training to study individuals, rheumatic and autoimmune diseases with individuals with Down syndrome, and we're also supporting a clinical trial by an investigator called Joaquin Espinosa, looking at JAK inhibition in Down syndrome. And it's actually to evaluate the effects of tofacitinib on young adults with Down syndrome who have increased prevalence for alopecia areata, for baldness. Next slide, please. Another trans NIH program is called Improve, Implementing a Maternal Health and Pregnancy Outcomes System for Everyone. This was launched in 2019. It supports research to reduce preventable causes of maternal deaths and improve health for women before, during, and after delivery, with an emphasis on health disparities and populations that may be disproportionately affected, such as racial and ethnic minorities, very young women, older women, and people with disabilities. And in 2022, the NIAMS was able to start supporting a clinical trial called the HOP-STEP intervention. The PI is Megan Klaus of Duke University, with the goal of enabling rheumatologists to provide equitable, accurate, and personalized pregnancy prevention and planning recommendations to women with SLE. Slide, please. And I will mention that I think this group may have talked about this in past seminars, that in 2023, the NIH or the Congress has apportioned $10 million to establish an Office of Autoimmune Disease Research within the Office of Research on Women's Health. And this, the idea of this is to help develop areas of collaboration and coordination among the different NIH ICs, and NIAMS is looking forward to working with the ORWH. Next slide, please. I will just spend 1 minute on some selected research advances. Obviously, this is just a couple that I picked out that appeal to me. One of them is a collaborative study identifies early indicators of pregnancy complications in women with lupus. So adverse pregnancy events occur in over 20% of women with lupus and or antiphospholipid syndrome. And the goal of this study was to maybe be able to identify early changes that could be used to determine the likelihood of developing these complications so that they can be, better addressed or treated. So by analyzing gene expression patterns from pregnant lupus patients or healthy pregnant women, the team identified a unique immune signature that could predict the development of preeclampsia more accurately than the existing clinical factors that we know about. And I just wanted to add on that one of the investigators in the study is Dr. Jane Salmon, who also is currently performing a trial called Impact, which is looking at treating women with antiphospholipid syndrome who have known to have an increased risk of preeclampsia and other adverse pregnancy outcomes. Now, looking at treating these women with anti-TNF, an anti-TNF that's been approved for other diseases, but to help them to retain their pregnancy, a healthy pregnancy. And it's a very exciting study. The publications are not out yet, but it's exciting work. Next slide, please. And in the world of rheumatoid arthritis, as well as in other autoimmune diseases, the microbiome is making a new show. It's for many years, the association with the little microbes that live on your body, that naturally live on your body, have been associated with immune disorders, with health and dishealth, disease. But really understanding the molecular connections has been hard to break down. But I think with modern technologies and collaborations, we're getting closer. So the first paper is actually Dr. Tabak, the acting director of the NIH, had this in his director's blog, Connecting the Dots, Oral Infection to Rheumatoid Arthritis. So in this paper, they show that bacterial communities lodged below the gum line may breach the normal barrier between the oral cavity and circulation, thus exposing bacterial components of the immune system, provoking immune response, such as producing autoantibodies or antibodies that then may cross-react with cell proteins, which would be autoantibodies. So their take home might be that early routine screening for periodontal disease may identify individuals at increased risk for RA, who then may benefit from early intervention. Next slide, please. And another one that came out very recently, and with some of the same authors, is implicating gut bacteria in RA. So as you may know, autoantibodies can be detected in individuals at risk for developing RA long before the development of clinical disease, but it's unclear what the source of these autoantibodies are. In the current paper, the investigators identified types of autoantibodies that cross-react against certain gut bacteria. And then they identified a particular strain that was particularly associated with autoantibody development. Using a mice model, if they put this strain, I'm not going to try to pronounce it, subthalagranulum, into the mouse, these mice developed arthritis with pathology similar to human RA. So these findings suggest that this strain may be a major contributor to RA autoantibody development. And obviously these studies need a lot more development and looking into humans, but it really raises a lot of interesting questions about the role of the environment and of diet, of these factors of our own microbiome and in inducing autoimmune diseases. Next slide, please. And I just listed some resources for you to take a look at. And then the next slide is ways to connect with the NIAMS to get our newsletters, et cetera. Thank you very much. Next slide just says thank you.
Thank you so much. Really appreciate you going over all that. We are very eager to see what happens with the Office of Autoimmune Disease Research within the Office of Research on Women's Health. And I would love to circle back to that during the Q&A portion, but also appreciated you sharing a few of the recent findings from studies that are happening. A lot of really interesting stuff there. So our next presentation is going to be from Dr. Nicole Boschi with the National MS Society. She's here to kind of discuss the patient perspective with us and then give us some insight into how federal entities like FDA and CMS can help support women with autoimmune diseases and conditions. So Nicole, I will now turn it over to you.
Thanks so much, Lindsay, and thank you to the Society for Women's Health Research. I'm really excited to be part of this panel and to have this discussion with you today. So I'll start by very quickly defining multiple sclerosis. More than 1 million Americans live with multiple sclerosis, and the disease is 3 times more common in females than males. In MS, the body's own immune system attacks the central nervous system, causing damage, which slows or stops nerve transmission. This can lead to unpredictable symptoms such as mobility issues, fatigue, blindness, and cognition changes, among other issues. So I'd also like to level set by providing a very brief, high-level overview of a few federal agencies that I think are relevant to today's discussion. So first, I'll talk about the Centers for Medicare and Medicaid Services, or CMS. CMS is the agency that works with state governments to manage Medicare programs and administer Medicaid and the Children's Health Insurance Program, or CHIP. CMS makes many decisions that affect coverage of drugs and devices. Although these decisions directly impact those on Medicare, many employer-based insurers often follow CMS's lead. Although, according to society data, approximately 25 to 30% of people with MS in the US are on Medicare, and around 5% are on Medicaid. About 30% of people with MS are on disability. And this is according to a 2019 Access to Med survey. So secondly, I'd like to talk a little bit about the US Food and Drug Administration, or FDA. The FDA's role is to evaluate the safety and efficacy of drugs that are used to treat autoimmune diseases and conditions, such as rheumatoid arthritis, lupus, and multiple sclerosis. One of the divisions of the FDA, the Center for Drug Evaluation and Research, or CDER, works closely with drug manufacturers and clinical researchers to review the results of clinical trials and to ensure that new drugs are safe and effective before they're approved for use by patients. Important access to safe, timely, and effective treatments for women with autoimmune diseases and conditions is really important because lapses or delays in treatment can lead to irreversible damage for these patients. This is especially true for MS, as we know that delaying access to a disease-modifying therapy, or DMT, can lead to irreversible disease progression and disability. Although we all want drugs approved quickly so that they can be accessed by those who need them, I'd like to take a minute to focus on safety. In the MS space, those living with the disease are fortunate to have over 20 approved DMT treatment options. This allows individuals, in consultation with their provider, to choose the treatment options that would be best for them, weighing safety and effectiveness. This also sets up a risk-benefit decision-making process. However, risk-benefit can only be well assessed if there's robust patient engagement and data for people with MS to utilize as they have these conversations with their healthcare providers. Because I know that we have a lot of policymakers and thought leaders on this presentation, I want to provide some thoughts about how agencies can engage in authentic patient engagement. So the federal agencies need to prioritize engagement with individuals who are living with chronic diseases and their care partners. This engagement needs to be authentic and not just checking the box. Let's also think about the word patient. Often the word patient has a negative connotation that implies the individual is defined by their disease, that they're sick, that there's something wrong with them. I encourage all stakeholders to interact with those living with chronic diseases on a human level and see patients as a partner. To have meaningful engagement at federal agencies, there needs to be the staffing capacity and resources, as well as a diverse workforce. For example, the FDA recently opened up applications to be on their patient engagement collaborative. However, only 70 applications were to be reviewed. This was a struggle for individuals who really wanted to apply for this program, especially those living with MS who may have cognitive and fatigue issues. Also, in general, it was a struggle to get applications in for those who had busy lives. And I know that so many more people really wanted to apply, but unfortunately that 70 application threshold was reached pretty quickly, and a lot of applications were essentially left on the cutting room floor. And I know this was very well intentioned by FDA, but I know that this was likely due to a shortage of staff to review applications, so that's why they cut it off at 70. Also, people with chronic diseases, and especially those of minority or marginalized communities, feel most comfortable sharing their experiences with whom they have built trusted relationships, who look like them, who have similar shared experiences. Many people with MS do not access or routinely see an MS specialist, healthcare provider, and some are not even connected with the healthcare system in general prior to diagnosis. When people are in an unfamiliar setting with those that they don't know, anxiety is increased and their likelihood to participate in a feedback study is decreased. We encourage all stakeholders, including federal agencies, drug manufacturers, CROs, and others, to prioritize work with community-based clinicians who are in tune with the local patient community and who can offer care in a culturally sensitive way. interaction with different communities and with different types of patients is essential to collecting and understanding the diverse array of perspectives. We encourage all stakeholders to examine whether they're making assumptions regarding the readiness of individuals to provide the type of information that they're looking for. The Society suggests that agencies educate patients on the type of studies and the impacts of the metrics that are being collected and studied, and to use lay terms in an individual's preferred language. This goes beyond the informed consent process, and this education is critical to ensuring that patients are providing more meaningful data, which will be more useful. Agencies also need to inform individuals how the information that they share will be used. Patients want to know what the results of these interactions are, and they deserve to know how their contributions have influenced policymaking and other decisions. So next, I'd like to go into what the role is for patient advocacy organizations, such as the National Multiple Sclerosis Society. So federal agencies need to prioritize meeting with individuals living with a disease, not just the patient groups. Although patient advocacy groups can help facilitate this interaction, federal agencies need to hear from the patients themselves to understand what the disease looks like at a human level. When facilitating patient engagement, advocacy groups should put forward a diverse list of individuals, both racial and ethnic diversity, geographic diversity, and a diversity of lived experiences. Patients and patient advocacy groups need to think about how they can help the agency understand their challenges and drive change. So thank you so much, and I'm happy to take any questions later.
Thank you so much. I really appreciate you kind of touching on the patient perspective and then providing some insights given your work in this space day in and day out. Our last speaker today is Ms. Taryn Williams, Assistant Secretary. So Ms. Williams, I will turn it over to you.
Great, thank you so much. And thank you for having me here today. As you heard, I had the pleasure of serving as Assistant Secretary of the Office of Disability Employment Policy, or ODEP, as we call it for short, in the U.S. Department of Labor. We are the only non-regulatory federal agency that promotes policies and coordinates with employers in all levels of government to increase workplace success for people with disabilities. Next slide, please. And next slide. Our mission is to develop and influence policies and practices that increase the number and quality of employment opportunities for people with disabilities. And at the outset, I really want to note that I am a woman living with a disability and someone who strongly believes that the perspectives and life experiences of people living with disabilities and chronic conditions adds value. That's true in the public sector, the private sector, and truly every organization. I speak from my own experience. I was diagnosed with ulcerative colitis at the age of 5, certainly grappled with symptoms and many treatments. And then as I moved into adulthood, my condition evolved, as is so often the case with autoimmune conditions. And now living with both inflammatory bowel disease and enteropathic arthritis, I rely on a 28-day cycle of infusions for treatment. And the reliance that I have on treatment and on healthcare, and that ever-present uncertainty about inflammation and chronic pain and fatigue truly affects what I do, and particularly my work. And I should note that I deliberately choose to disclose my conditions because I believe that women often receive messages in the workplace and in broader society that lead us to mask or downplay the impact of these conditions on our lives. And that in turn can impact access to the supports that we need to thrive. Our work at ODEP encompasses all workers with disabilities, all types of disabilities, both visible and non-visible. Next slide, please. Including the estimated 36 million women with a disability in the United States in 2021. Women with disabilities face stark disparities in the labor market. In 2022, the unemployment rate for women with disabilities was 7.4% versus 3.4% for women without disabilities, so more than double. And the labor force participation rate for women with disabilities was 21% versus 62% for women without disabilities. It is absolutely critical that we close the employment gap for women with disabilities because we believe at the Department of Labor that work is fundamental to our identity. It's about independence. It contributes to our sense of self, and it's also a powerful social determinant of health. But for this to happen, we need supportive workplace cultures. And on that note, this year marks a milestone in several ways. We are celebrating the 30th anniversary of the Family Medical Leave Act, or the FMLA, and the 50th anniversary of the Rehabilitation Act, or the Rehab Act. And these landmark laws created critical protections for women and people with disabilities. The Rehab Act, next slide please, was the first federal legislation to address notions of equity and access for people with disabilities. It prohibits discrimination on the basis of disability in employment by federal agencies, federal contractors, and recipients of federal funds, as well as in the provision of federally funded programs and activities, for instance, employment services. These protections were expanded more broadly with the passage of the Americans with Disabilities Act, or the ADA. And since 1993, next slide, please, FMLA has ensured that millions of workers in America don't have to choose between maintaining employment and meeting personal responsibilities. These responsibilities, as we all know, include managing one's serious health conditions. So for many people, the FMLA is key to retaining employment after the onset of disability or undergoing treatment for a chronic condition. That said, we still do not have a federal law that provides paid family or medical leave for workers, so our work is certainly not done. These laws were great advancements in supporting workers with disabilities, but it must be noted that these gains haven't always been equitable. As I shared earlier, the employment rates for certain groups, including women with disabilities, continue to lag. And for women of color with disabilities, the disparities are even larger. So how do we increase equity? Next slide, please. To start, workers and employers must understand who the ADA covers and the protections it provides. I speak often to groups, and so many times people will say, well, I don't have a disability. I just have this condition. And the ADA does not include a list of conditions. Rather, it says that a person with a disability is someone who has a physical or mental impairment that substantially limits one or more major life activities. Next slide, please. And in an employment context, it's important to note what a qualified person with a disability is, because that's who's protected. Qualified means someone who satisfies the job-related requirements of the position and can perform its essential functions with or without a reasonable accommodation. And accommodation is any modification to the work environment or the way that the job is done that enables someone with a disability to apply for or perform a job. Under the ADA, employers must provide accommodations for applicants and employees with disabilities when requested, unless doing so would cause an undue hardship. And while accommodations are individual in nature, there are common examples for workers with autoimmune conditions. For instance, flexible scheduling to assist in managing appointments and the side effects of medication. Something I use, also closer access to or increase bathroom breaks, which is another accommodation that I've used. And through our job accommodation network at ODEP, or JAN, as we call it for short, we assist both workers and employers to understand accommodations. JAN is the leading source of free, expert, and confidential guidance on accommodations, and you can learn more about JAN at askjan.org. Next slide, please. I'd like to close by just talking just a minute or so, because I know we have questions, about our efforts to support people experiencing a new condition affecting millions of Americans, but one that has overlapping symptoms with many chronic conditions, and that is long COVID and its associated conditions, which can last weeks, months, or even years. It is critical to state that long COVID is real, and that supporting workers with long COVID is a priority, not only for us at the Department of Labor, but across the entire administration. Leave is a critical support for those with long COVID, and the FMLA and ADA can help here as well. I will also note that since symptoms of long COVID may include mental health conditions such as anxiety or depression, we've also been educating employers on how to best support workers experiencing them. And one aspect of that is accommodations, which we talked about earlier, but it's also about awareness, providing employee assistance, and ensuring access to treatment. Next slide, please. You can see more about how to provide those supports to employees at askearn.org. And in that, it'll go into more detail about how to build mental health friendly workplaces. And I think I'll close with just one final point. And most of the strategies that I've talked about today and that you'll find in our resources are really just smart practices that benefit all employees. And regardless of condition or limitation, we are committed to helping workers with disabilities, including women with autoimmune conditions, succeed, and helping employers benefit from their skills and talents. So, as I said earlier, this is not just professional for me, it's personal. And thank you again for having me on the panel today.
Thank you for joining us. And Ms. Williams, I'll start with a question to you. And maybe while I do, I'll invite our other panelists to turn back on their cameras for the Q&A portion of the event. But Ms. Williams, you'd mentioned that women often feel that they need to mask their disability or their condition, and we so appreciate you sharing your own experience. But what would you say to women in the workplace who are navigating life with an autoimmune disease or condition about going to share that with an employer if they so choose to?
Sure. I would say what I counsel colleagues and friends to do all the time, and that is truly it can depend on what sorts of resources you're seeking. We offer a ton of resources at ODEP that can help you in staying on the job even after acquiring a chronic condition or as that chronic condition evolves. As I noted earlier, one key resource is the Job Accommodation Network. I say quite candidly, I've used it. I've used it as an employee myself. I've used it as a manager to help to provide the supports needed in the workplace. And truly our goal is to ensure that people don't have to face a choice between staying on the job and having to leave the workforce because of these conditions. And there are so many resources out there that can be of support to them. And it starts with disclosure.
Thank you. And I'd like to actually build on that point. So you mentioned the Ask Jan network. I'd like to open it to all of our panelists. So where would you direct women, whether they've been recently diagnosed with an autoimmune disease or farther along in their journey, to start when it comes to finding federal resources? I know your respective agencies or the agencies you work with all have a lot available, but often we face information overload whenever we're trying to find something. So where would each of you direct individuals to go for assistance?
I can start. So the National Multiple Sclerosis Society, we have a very dedicated team of navigators who are well versed in a variety of resources. So I would direct you there. And I'm on our website right now, and you can just click on the button that says chat with a navigator, and they will take care of you.
Yeah, I would add that our institute's website certainly has a lot of information on various autoimmune diseases. Not every autoimmune disease, because some are not necessarily within the mission of NIAMS. So you sometimes have to dig a little bit to figure out where you can get that information. Some of it may be through other institutes or centers at the NIH. And of course, there are a lot of patient-oriented organizations that that will come up when you search for information. Like with everything, you have to be careful that you're getting a trusted source of information.
Thank you all so much. My next question would be, I think this panel, convening this panel here today has really demonstrated the complementary work of federal agencies to support individuals navigating autoimmune diseases and conditions. I would love if you all could address briefly how you communicate with other public health and research agencies. I know that the AMP-AIM program is a collaborative program, maybe addressing how initiatives like that might come about, or how you work with other federal agencies on kind of a day-to-day basis. Maybe Dr. Mancini, we can start with you, if that works.
Sure. Yes, as you mentioned, there are several overarching programs at NIH, and I think these are more common. For instance, one that's been getting a lot of attention lately, as it should, is the Helping to End Addiction Long-Term HEAL initiative, which is focused on one part is focused on ending addiction, and then the part's focused on understanding pain. And as you know, pain is a very significant factor in autoimmune diseases. So there are several, so the NIAMS and other autoimmune disease supporting ICs are very much involved in HEAL. And there are other these overarching programs funded through what we call the Office of Director, or maybe through like sort of trans NIH funding. There's the BRAIN Initiative, which is Alzheimer's, also has elements of definitely inflammation and maybe autoimmunity. I think we're finding that the body's complicated, right? The NIH was formed with these, this institute will do this, the institute will do this, but it's all connected. And I think immunology, I'm a little bit biased as an immunologist, that the immune system is so important, and we're finding out new things all the time. So there are these large programs that the different ICs work together. I noted that the NIAMS hosts the Lupus Federal Working Group. There are other such groups as the Autoimmune Disease Coordinating Committee, which is a similar group hosted by the NIAID, which gets together to talk about global issues in autoimmune disease. And they recently were able to put out a grant solicitation focused on Crohn's disease. And currently they're talking about fatigue in autoimmune diseases. So in that way, we're able to, but I agree that it is confusing and a little complicated in how the different money flows and the organization. Thank you. And if others have anything to add.
This is Taryn. I'll just say quickly that sort of grounded in our mission and the reason for our founding is to coordinate across all levels of government and particularly at the federal level. It's in recognition of all of the supports that must be in place to ensure that an individual with a disability, someone living with a chronic condition, can be successful at work. And so that takes the form of coordinating committees and sitting on many interagency work groups. It also means working in collaborative nature with a lot of different departments, such as Health and Human Services, Transportation, Social Security, and many others that I could name, just to ensure that the person gets the supports that they need, the coordination and the funding in order to thrive both at work and in their communities.
Thank you. And I know we're nearing time. I want to be respectful of your time, but maybe if we have time for one or two more questions for our panelists. So going to an audience question, we had someone ask, now that more women are often in the workforce for their whole careers, what have we learned about autoimmune conditions and career longevity?
That is a great question. I can speak from our perspective at ODEP and really reflecting on the Department of Labor. While we have seen some success in closing the gaps, I mentioned some of those data earlier, those data disparities that exist in the employment of women with disabilities. And I'll caution here because I'm speaking broadly of women with disabilities and not disaggregating them by the actual condition, but we still have quite a bit of work to do. We have a lot of work to do in our workplaces, combating stigma, combating something that I was talking about before, which is the ways in which we're compelled to perhaps mask or not disclose our disability, therefore not accessing the supports that we need in the workplace, from employer assistance programs or the leave that we need in order to care for ourselves. And until we're able to do that, until we are a society that is truly committed to building those successful workplace cultures and supports, I do think we'll continue to grapple with those disparities.
Great. And my final question, just to close us out. So on the phone, we have patients and patient advocates. We have some policymakers. We have some members of industry. So thinking about the broad groups of audiences that we have on the phone, based on the information that we discussed here today, what's one thing that you would like for attendees to take away from this conversation? And maybe I will go in the order in which you presented. So Dr. Colbert, we'll start with you, and then Dr. Mancini, Dr. Bashi, Ms. Williams.
I would start by saying that patient engagement in research is such an important part of what we do now. I work with through my my position in NIAMS, but through my other efforts with other organizations dedicated to research. It just adds such an important component to perspectives, whether it's patient-reported outcomes, how you design studies that are patient-friendly. I mean, studies have to be designed appropriately to get to be able to answer the question you're asking, but getting input from patients just really informs the process, and it helps with recruitment. So I'll stop there, but I think patient engagement is something that needs to continue to be emphasized.
Thanks. I'd just like to mention that I hope people think more about the importance and role of team science. That's been something that we talk about a lot at the NIH. So my job, I'm mostly supportive of researchers. I'm not a physician, or I don't directly deal with patients. But I think we've seen a lot of wonderful advances lately through the team science, being able to pull together resources such as a private public partnership that AMP is, and the new technologies that are coming out to really start dissecting and understanding diseases, which will make its way into patient care. Thanks.
I'll just add to what Dr. Colbert said. It really needs to be authentic patient engagement. Meeting patients where they are, talking to them in their preferred language, with people who look like them. As I said, a lot of patients really want to participate in research studies, but either aren't asked or are not in the right setting where research is being done. I think authentic patient engagement and really seeing the human side, not just the disease, but talking to patients as humans. I think that's really what is essential to moving the needle.
That's something I'm going to build on, and that is simply something I said earlier, which is that women and men living with autoimmune conditions may be entitled to protections in the workplace. And we'd never want concern about the word or their understanding of what disability is to get in the way or be a barrier to those supports in the workplace. And please do make my contact information available, because we would love to be in touch with anyone who wants to learn more about our work.
What a perfect note to end on. I would like to thank our panelists again for their willingness to contribute their time and expertise, and for me monopolizing a few extra minutes of your time at the end of this event. As Katie mentioned at the top of this event, this is one of a 4-part webinar series. The first 2 are posted online. The 4th will be held soon. More information to come, but will be focused on diversity within autoimmune clinical trials. So thank you all for attending. We really appreciate it, and we will see you soon.